Thank you, Madam Chairman. First of all, I want to thank everybody that helped me put this meeting together. We had a combined effort, and I'll be quite honest, they did most of the work, put together the speakers for me, and Linda and my LA Candy did most of the work, so I want to thank you all for that work prior to starting this. I know this whole issue, to say is controversial and emotional, is kind of an understatement, and I realize that it is one that is not an easy one, and it is one that to me has affected my life and affected a lot of my friends who have experienced some tragic instances with relatives, and I got torn up about it, brought into it with the young lady Brittany. I can't remember. Yes, the one that went to Oregon. And I got to watching that after the death of my mother, and I thought, that's something that we ought to look at in Oklahoma. And for the last couple of years, I've filed legislation dealing with it, and have not gotten very far. But I think a lot of it, I've gotten a lot of letters, and I think in the packets, if any of y'all would like to pick up some packets, you'll see some letters I received from people. I didn't send out a press release on it, and didn't do a whole lot of advertising about it, but the word got out, and I did get a lot of response from people who went through the same thing. This is one of those cases where it's easy to make judgments about it unless you've been involved with a case that deals with it, and you've had a personal relationship with either a family member or a friend. I've had friends that one had Lou Gehrig's disease, and my sister had cancer. I had an aunt that had emphysema. My mother had strokes. They all went through a very trying period at their end of life. And I think something like this is something, if they had had an option to consider, they might have considered. So that's the reason I asked for the study and have proposed the legislation. And myself, as well as the rest of you, I know there are a lot of people we have on the list that are extremely knowledgeable about the whole situation, much more than I am, because I'm a novice at it. Like I said, I got drawn into it because of that one case and thought it made a whole lot of sense to give people options and choices. We talk a lot about choice in this state, choice for education, choice for other things. But I think this is a choice we should give someone who finds himself in this situation. So that's the reason we're having the study, and hopefully, even if legislation is somewhere down the road, this study will bring together some information that can be utilized by a great number of people in the state and get the discussion going, and maybe move the train down the tracks just a little bit. So that's kind of why we're having the study on my part, and we have a really good list of speakers to kind of explain the whole death with dignity issue. And first, I'd like to ask Gavin if he would come forward. He's currently Director of Clinical Ethics for Integris Health, and Gavin Eck is really knowledgeable about this subject, and he's going to explain to us, if I understand correctly, exactly what the Oregon legislation says and does. Gavin. Thank you.
Thank you.
Representative Copeland, can I just comment here that you would like us to wait till the end of all the presenters before we ask questions? Is that right?
Yes.
And people will be allowed to ask questions. We don't have legislators here, but we should have time to accommodate those. So thank you.
Hello. So my name is Gavin Ink. Just a quick introduction. I'm the Director of Clinical Ethics for Integris Health. After finishing my PhD at the University of Tennessee in philosophy, I did a clinical ethics fellowship at MD Anderson, where I worked in their acute palliative care unit. I worked in their ICU as well as a full-time ethicist. I also worked across town at Memorial Hermann on their CAPS team, which was care for pediatric palliative care patients. And I've recently been brought to Oklahoma to work for Integris to create a clinical ethics consultation service. I'm not speaking here as a representative for Integris. I'm just here on my own volition, trying to give some information about what is Oregon's Death with Dignity Act and law. The first thing I want to start off with is what it is not. All right? Death with Dignity, this act is not euthanasia. Okay? That's important to understand. Physician aid in dying is where a patient requests from a physician a prescription. The patient then takes that lethal prescription and then takes it to end their life. What euthanasia is where a physician intentionally and directly ends a patient's life. All right? There are two types of euthanasia. There is voluntary euthanasia, where a patient says, I want this to happen, I want my life ended. And there's non-voluntary euthanasia, where we do not know what the patient's wishes were. Euthanasia is legal in many parts of Europe for adults. It is legal in the Netherlands and Belgium and Luxembourg for both adults and for pediatric patients. Euthanasia is illegal in the United States. All right? So physician aid in dying is not the same thing as euthanasia. Now, is a patient who requests to forego life-sustaining treatments the same thing as euthanasia or even physician aid in dying? No. All right. Why not? Patients have an ethical right for self-determination, all right, based on the ability to make their own choices, based on their values, personal beliefs, and an own bodily integrity. They always have the right to say they don't want further treatment. All right? It's important to remember that when a patient says, I do not want further treatment, they are not saying that because they're trying to hasten their death. They are saying that because the burdens and risks of further treatment are too much. All right? So to begin, physician aid in dying and Oregon's law is not the same thing as euthanasia. And the second is patients always have the right to say no, even to life-sustaining treatments. You're going to hear me talking about the Oregon law mostly because it is the first one that was done, it is the most famous, and it is the one that most other states have patterned their legal statutes after. All right? It was started by a voter referendum in 1994, and it was enacted in 1997. It took 3 years of legal challenges for it to get going. The first thing that's important to remember is that physicians are not required to participate in it. So if a patient makes this request to a physician, he's not required to act on it. For patients to participate in this program, they have to be an adult, 18 years and older. They have to be competent and with decision-making capacity. All right? It's important to make that distinction. Competency is a legal term. All right? When you are declared incompetent by a judge, usually off of the basis of medical information, you lose all of your rights: the rights to own property, the rights to vote, to do your own finances. It's a severe form of marriage. Sorry, my wife hates that joke, but I had to get it on the record. What decision-making capacity is when a patient can make their own decisions. All right, they are able to make their own decisions in a particular instance. So again, for Oregon, they have to be over 18, they have to be competent, and they have to be able to make that particular decision. The last thing is they have to be diagnosed with a terminal illness with 6 months or less. All right, so have to be diagnosed with a terminal illness. Now, in order for them to participate, they do this. What is their request process? They have to make 2 oral requests to their healthcare provider, separated by 15 days. They have to have a written request that is in the presence of 2 witnesses. There has to be 2 physician consultations to make sure that the diagnosis and prognosis is correct. One of the physicians confirming it is the prescribing, the other is a consultant. And the 2 physicians also have to be able to say, this patient has decision-making capacity. If there's a question about it, if they feel that the patient is impaired, is unable to make this decision, they can request for a further psychiatric evaluation. The prescribing physician must also inform the patient of feasible alternatives, all right, such as palliative care, hospice care, to control their pain and symptom management during end-of-life care. The last part is the prescribing physician may request, but they cannot require that the person getting their lethal prescription must inform their family. All right. Now, what is this lethal prescription? It's usually a barbiturate, mostly phenobarbital. A patient usually drinks either 10 grams of it from the liquid or takes 9 to 10 grams of the capsules, dissolving it either water, or applesauce. And the reason why applesauce is it has a very bitter taste. They're also suggested to do anti-nausea medicine an hour before taking it. And the reason being is that regurgitation is the most common problem occurring during this. In all cases, if you look in the 18 years that Oregon has been doing it, in about 5% of the cases, patients regurgitate the medicine. The reason why that is problematic is because once a patient swallows the prescribed dose, it is illegal to take any additional measures to hasten their death. All right? In Oregon, according to Oregon law, not only do they account every year for everyone who has fulfilled or gotten one of these prescriptions, they also send a questionnaire that goes out to them. What they've been able to attain, at least in 2015, is that after ingesting the medicine, on average, it takes anywhere from 5 minutes to 34 hours for a patient to die. Right? In Oregon, since 1997, 1,545 people have received the lethal prescription. 991 patients have died from ingesting it. All right. In 2015 alone, 106 physicians wrote 218 prescriptions. And out of those 218 people receiving those prescriptions, 125 ingested the medication. In 2015, all 125 who ingested the medication passed away without regaining consciousness. 7 people who had prescriptions from previous years also used the medication and died without having regurgitated. 50 people did not take the medicine and subsequently died of their underlying condition. And the ingestion status for 43 patients was not known. 5 of these patients were lost, meaning that their follow-up to their questionnaire was not submitted or received in an appropriate time. And so 38 patients, we are unaware, at least at this moment, of what their status is in terms of ingesting the medicine or death. So, for Oregon, their characteristics, which has actually been pretty similar throughout the years that they've had it, is that 78% were aged 65 years or older. The average median age was 73 years. 91% were white. 43% of them had at least a BA for a college degree. And the top reasons or medical conditions for this was 72% was cancer, 6% was ALS, and close to 7% was heart disease. 90.1% died at home, all right? Which is statistically actually very interesting because the vast majority of patients die in a hospital, all right? Sorry, I used to be a philosophy teacher, so I'm resisting the urge to poll the people here, and so. Yeah. Of those who died at home, of all these patients, 92% were enrolled in hospice. 99% had some form of health insurance. 32% had private insurance, which was actually lower than the previous year. 62% only had Medicaid or Medicare, which was actually significantly higher than the year before. Their top reasons, patients' top reasons for getting the lethal prescription were number one is it was a decreased ability to participate in activities that made life enjoyable. Number two was a loss of dignity or loss of autonomy, and the third was a loss of dignity. All right. In 2015, there were no request or notification sent to the Oregon Medical Board of any inappropriate use of the prescription or the prescription process. Washington, which was the second state to adopt a Death with Dignity Act, basically you could say plagiarized, took all the statutes from Oregon because it is the model, changing very little. And so that was actually started by a voter referendum in 2008, and it was passed with 58% of the vote, enacted in 2009. Out of their sum total, they've had 938 prescriptions have been given to patients, and 917 have died. However, I have to point out that they do not, in Washington, have a running aggregate of how many of those who died per ingesting the medicine or died of their underlying causes. They do that by statistical year. They don't keep the aggregate of that going. In 2015, 213 individuals received a prescription. 142 different physicians wrote prescriptions, and these were dispensed by 47 different physicians. Out of the lethal prescriptions that were dispensed to 213 people, 11 participants, the health department has not received any documentation or a death certificate or the follow-up toward the mandatory time to know what has happened to them. 202 have died. Right? 166 died ingesting the medication, 24 died without ingesting the medication, and 12 people who died, but their status of their ingesting the medicine was unknown at the time. The patients, very similar, their characteristics are very similar to Oregon. They had an average range of 20 years old to 97 years old. The number one reason medical condition was cancer at 72%. 8% had a neurodegenerative disease, such as ALS, and 20% had some other illness, such as a heart condition or respiratory illness. Of the 192 participants in which they did receive a death certificate, 98% were white, non-Hispanic, 47% were married, and 74% had at least some college education. Out of the 166 persons who did die from a lethal prescription, 86% were at home at the time of death, and 81 were enrolled in hospice care when they ingested the medication. Of the 197 participants who were in this and got an after-death report required by the state, 95% had private insurance, Medicaid, or Medicare, or combination of both. All right. Again, their reasons, patients' reasons for wanting this were almost exactly the same as they were in Oregon, which was a loss of autonomy, loss of ability to participate in the activities that makes life enjoyable, and a loss of dignity. All right. There have been two major concerns about, both in Oregon and Washington, about the Death with Dignity Act. The first is that Oregon would become a death tourism location, so people would move there specifically to die. It has not. All right. In part, it hasn't because you have to understand that a person taking this route, which is physician aid in dying, is actually pretty rare. It is 38.6 per 10,000 deaths in Oregon. In Oregon, only 1% of end-of-life participants make the request, and out of those, only 10% of those actually receive their lethal prescription. And we have to remember that getting this prescription requires a degree of foresight, a degree of planning, and the ability to map out what your future states are going to be. And that's very difficult for people to do in stressful situations. The second concern was that this law would weaken or erode both pain management, symptom control, palliative medicine, as well as hospice care. And in fact, it has not. And the reason being is the 3 years between when this law was, the voters voted on the law versus it was enacted, Oregon healthcare leaders actually made a concerted effort to educate all their physicians about what good palliative medicine is, as well as hospice care. And they did this to make them comfortable with these situations and getting it out there. And in doing this, they found that most physicians in Oregon are now far more comfortable getting hospice and getting palliative medicine involved in patients. I should point out the average stay across the nation in hospice is 12 days. All right, why? In a study out of the University of Texas, they actually showed that patients who had life-limiting conditions, terminal conditions, and were in the final stages of their life, 1/3 of them, were not told what their prognosis was in terms of that they had weeks to live, and 2/3 of them were never informed that hospice was an option. So Oregon is already ahead of the stage of making our patients aware that there is palliative care and there is hospice mentions. And I should also point out, having worked at MD Anderson and other places, the best thing to improve a patient's quality of life as well as symptom management, right? Allowing them to live the life that they most so choose. So those two significant concerns turned out to be unfruitful there. In other states, the Death with Dignity Act is picking up steam. As I mentioned, Washington, Montana. There's also Montana, Vermont, and California. Montana is interesting and slightly scary because what it is their Supreme Court said that terminal patients have the right to get physician aid in dying. However, as of today, there is no structured process that they're going for. So there is no reporting process. There is no mechanism to track all theirs. It's just considered a right that their state Supreme Court has given a terminally ill patient. In other states, like Washington, again, follows Oregon. Vermont also follows the same pattern as Oregon in terms of how to make a request physician participation, and so forth. However, they do not generate a yearly report. And California, as recently as 2015, has gotten this signed by the governor, and they follow the same pattern too, which is 2 requests, time in between going forth, basing it solely off of the Oregon model. I should point out, as of today, is both New Mexico and New Jersey are still in the process of trying to get this law put forward. I know New Jersey, as of last week, it would just pass their assembly. So now they're moving it forward on. So that is a brief overview of how the law is in for Oregon.
Thank you. You're right on your time limit.
Yeah.
I really appreciate that.
Yeah, I can take it.
And can you tell me how to pronounce your last name?
My last name is Enk, so it's like tank with an E. So, Enk.
Thank you. Okay.
Thank you very much. I'm sure there are a lot of questions at the end for you because I've got a few myself. The next presenter is Philip Reddick. He's a doctor with the College of Oklahoma College of Medicine. Been there since 1979. He currently serves as a key member of the Oklahoma POLST Task Force, which is Orders for Life-Sustaining Treatment. I saw. Thanks, sir.
Thank you, Representative McDaniels, Representative Copen. I'm going to sort of read my remarks. That way I'll stay on time and follow along. So my name is Phil Reddick. I'm a retired pediatrician. I previously was on the faculty at the OU College of Medicine and at Oklahoma Children's Hospital. For over 25 years, in addition to my clinical, teaching, and research responsibilities there, I served as co-chairman or chairman of first the Ethics Committee at Children's Hospital and then the Hospital Ethics Committee at OU Medical Center. In this capacity, I interacted with and provided recommendations to many patients, families, physicians, other providers dealing with end-of-life issues. My words today are going to reflect what I've learned over those many years and from many of these encounters. My statement represents my thoughts alone and certainly not any official pronouncements or policies from either OU Medical Center or the OU College of Medicine. A major principle which guides our current ethical approaches to patient care is respect for patients' autonomy, as you've already heard from Gavin. The right of an adult with intact decision-making capacity to make informed decisions about what medical care he or she wishes to accept and what therapies he or she might want to refuse. This principle underlies the patient's right to consent to surgery, to follow or to refuse, to follow a suggested treatment regimen for cancer, the right to donate organs after death, the right to decide to refuse CPR when facing a terminal illness, the right to complete an advanced directive form. Balancing the principle of autonomy are the two what I call mirrored principles of beneficence, to do right for the patient, to do right by the patient, and non-maleficence, or the principle of avoiding harm to patients. When our patients face end-of-life decisions, we must carefully do our utmost to be sure that the recommended treatments are likely to provide benefit without exposing patients to undue harm. Beneficence includes actions to cure illness, to prevent disease, to repair or rehabilitate injuries, to provide comfort, and to reduce pain and suffering. These last two spheres of treatment are really the mainstays of palliative care. They often are the best modes of care for patients facing a terminal illness, and they certainly most fully meet the duty to not do harm because they provide comfort and they lessen patients' terminal pain and suffering. The emergence of palliative care over the last several decades as a first-line core component for patients at the end of life has greatly improved such care for many patients over their last days or weeks. We teach our students, or I taught when I was still teaching them that, and our residents that it is never appropriate to, quote, stop everything, or to tell a patient or family that, quote, there's nothing more to do. There's always something more. We instead should strive to change therapy from curative to palliative and do everything we can to relieve suffering. However, unfortunately, despite the wider application of palliative care, improvements in multimodal pain management and relief, some of our dying patients still have severe, unmanageable pain and suffering in their terminal stages. It's for patients such as these that death with dignity bills have become law in several states, as you've heard. There are rare patients for whom the best palliative care available and the most intensive pain management are not sufficient. This bill gives such patients the right to request prescribed medication from their attending physician, which they can voluntarily ingest to end their lives painlessly in a final act of autonomy. This bill allows a compassionate physician who fully knows the patient's medical conditions, their psychological soundness, and their voluntary decision-making capacity, allows the physician in caring for such a patient to provide such medications. The decision to pursue this pathway must never be made casually by the physician. The patient and the patient alone must opt for this after repeated discussions and must provide truly informed consent. The physician who responds to such a request must be the care provider who best knows the patient's diagnosis, prognosis, mental status, and emotional state. The AMA Association, the American Medical Association's Code of Medical Ethics, which last addressed this, by the way, in 1996, states, quote, "Instead of participating in assisted suicide, physicians must aggressively respond to the needs of patients at the end of life. Patients should not be abandoned once it has been determined that cure is impossible. Multidisciplinary interventions should be sought, including specialty consultation, hospice care, pastoral support, family counseling, and other modalities. Patients near the end of life must continue to receive emotional support, comfort care, adequate pain control, respect for patient autonomy, and good communication." I fully agree with that statement, except for the introductory clause. I believe that there are rare cases where the sum of all these efforts that the AMA promotes still fail to adequately address our patients' terminal intractable pain and unmitigated suffering. The AMA also in that policy statement states, "However, allowing physicians to participate in assisted suicide would cause more harm than good. Physician-assisted suicide is fundamentally incompatible with the physician's role as healer. It would be difficult or impossible to control and would pose serious societal risks." In rebuttal to that, and remember this was written 20 years ago, I said I would contend that we can now look at 20 years of experience in Oregon for guidance in terms of the public's acceptance of and response to their death to dignity bill. We should be assured that in their experience and that of the other states which more recently have allowed death with dignity, that their experience belies these concerns. Such care, in fact, can strengthen the physician's role as a healer and a mitigator of pain. These states have established well-controlled programs without any evidence of significant abuses. And finally, there's been no slippery slope toward active euthanasia. Patients whose pain and suffering cannot otherwise be relieved will be rare. Physicians who are willing to provide this type of clinical care may be few. However, I believe that strictly limited and rigorously controlled regimen allowing death with dignity, such as outlined in the Oregon bill and the bill that Representative Copen has proposed, should become legal in Oklahoma. Thank you.
Thank you very much, Dr. Reddick.
Thank you, sir. Our next presenter, attorney Anita Prince, who is a licensed clinical social worker with a huge resume. I started to go through some of this, but the resume is extremely long, so I'm just going to turn it over to Ms. Prince and let her tell you a little bit about her resume and herself. Thank you.
Well, Representative Copeland, I'm not going to talk about my resume. That's not what I'm here to do today. I think if you looked at my resume, you'd think, well, the woman can't hold a job very long.
Overqualified.
That's, well, but I was an attorney for 20 years before I went to social work school, which is a little bit backwards in some people's mind. And then I received a master's degree from Loyola University in Chicago in bioethics and health policy. Now, this may seem divergent, but I am passionate about palliative care. I wish it were called comfort care, because when I first heard the term, I heard it from Linda Edmondson, who had to educate me as to what palliative or palliative means. It really means comfort care. It means pain relief, not just physical pain, but emotional and spiritual pain. And it applies primarily to people at the end of life, but if we go to get a root canal or a colonoscopy, I think most of us would want some comfort care to go along with that procedure. It makes sense, particularly for physicians and for the healing profession, to provide pain relief in any medical situation. But again, I'm not here to talk about myself as a professional. I am the director of the Oklahoma Palliative Care Resource Center at the Oklahoma University Health Sciences Center. I've been doing that for 10 years. And that organization was created as the result of a recommendation from the Oklahoma Task Force to improve end-of-life care in our state. I'm really here to talk as an Oklahoman. I was born here. I've lived here my whole life, despite the fact that my son joined the Navy and moved to Pennsylvania against my wishes. He had my grandchildren there against my wishes, and they have grown up there against my wishes. So I have a lot of frequent flyer miles, but my love is Oklahoma. And one of the things I love about Oklahoma is that we have always been a populist state. Right-wing populist, maybe, but from the beginning, we have felt like we could make our own decisions about important events in our life. And death is a very important event in life. It's a part of life. And as such, I would hope that we could plan for it the way I planned for my son's wedding to a good Catholic woman that I didn't choose for him from New York. The way I planned for my grandson's high school graduation this past summer. We come into the world with no choices. We really shouldn't have to go out of the world that way. Modern medicine's pain medication, as Dr. Rettig so eloquently explained, and he is my hero. I've been trying to get him to run for the Oklahoma legislature for what has it been, about 5 years, Phil, and he has nothing to do now. He's retired. He has no excuse. But pain medication and modern medicine has made us believe that there are cures for everything. And I think that's a part of the reason that hospice stays are so short. We want to fight. We want to fight death, and that's appropriate. And in my position, in educating palliative care physicians and consumers of palliative care, it is a very personal choice that I certainly respect, that we all should respect. But again, I'm not here as a member of the Oklahoma Health Sciences Center. I'm here as an Oklahoman. I'm here as an Oklahoman who watched my father die with pancreatic cancer. That was the first death I witnessed when I was 24. Then I was at my mother's bedside when she had an aneurysm. Very different experiences for me that I bring forward in my passion for palliative care for Oklahomans. Needless suffering should never occur for any of our loved ones or ourselves. If I have the choice at the end of my life, if I look just like my father, I am just like my father, I will not subject my son, my grandchildren, to experiencing that kind of death that my father did. I would hope that I would not have to go to Oregon because it's a long way from Pennsylvania. So my son would have to have frequent flyer miles to be there for me. But the British have a saying that Americans are the only people on earth who view death as an option. It isn't. We all are going to die. But one option we should have is that we not suffer needlessly. And as Phil explained, there are some illnesses that pain medication cannot quench. And that is the case for allowing a competent, mentally stable person to choose a death that will not include needless suffering and that will not subject their family to watching that experience. So I'm here as an Oklahoman. I love Oklahoma. I love it that we make our own decisions. And I hope that we can make this decision with the blessing of the Oklahoma legislature. Thank you.
Thank you very much, Ms. Prince. As another grandmother, my deepest sympathy for the Pennsylvania situation. I couldn't deal with that. Thank you.
I think an amen sister's in order after that speech. I'm right with you on that. The next presenter we have is Cecilia Smith. She's with the Silver-Haired Legislature, and I think they have passed some legislation similar to what this bill is. So, where's Ms. Smith? Is she not here? I thought, okay.
Do you know, Representative Copeland, if that has happened, the Oklahoma Silver?
It did pass. Yes, if you don't mind.
You can just state your name.
Hi, I'm Esther Hauser. I am the first vice president for legislation for the Silver-Haired Legislature, Oklahoma Silver-Haired Legislature. And in our session in September, the Silver-Haired Legislature did pass a bill that was brought by Cecilia Smith that is a death with dignity bill that's patterned after Vermont, which is almost identical to Washington, Oregon, almost identical to Representative Copeland's bill from last session, although it doesn't have a prescribed form in which physicians and others are to record information. The bill was passed in both the Silver-Haired House and the Silver-Haired Senate. It was not one of the 5 priority bills, but it received quite a bit of discussion. And that discussion was, I think, exactly as you would assume it would be. There were people who were who believed themselves to be opposed to people being able to direct their own death, have a death with dignity based on their religious beliefs. There were some, especially folks who'd experienced lots of other people's deaths in the medical field, who were very much in support of it. Some people with both experiences and conflicted about it, but the overall vote was in favor of having a death with dignity bill in Oklahoma. I will also say that although most of you probably don't know this, the first advance directive bills, the bills giving people the right to, the laws that we have now that give Oklahomans the right to choose and to record whether they want to be resuscitated, whether they want to receive artificial nutrition or hydration. Those were brought on the initiative of silver-haired legislators, members of the Alliance on Aging, members of other Oklahoma aging advocacy groups way back in the 1980s. And this was discussed widely, but it has been a sort of a leadership path for aging advocates in Oklahoma to try to secure those rights at end of life that we want as Oklahomans.
Esther, did you say that was in 2016, that's Silver-Haired Legislature?
Yes, September 2016.
Thank you.
Thank you.
Thank you. And the last presenters we have are a group of students from Tulsa, the University of Oklahoma out in Tulsa. They came and visited with me last session after seeing that I'd filed this bill and had done some work on it, and they asked to make some comments today. So I'll turn it over to Joy Miller Davis. She'll be the first presenter, and I think the other two also have a few things they'd like to say.
And Joy, if I understand, you are all students in the Masters of Social Work program at
That is
OU?
correct, in OU Tulsa
Thank you.
campus. Thank you. Madam Vice Chair, Representative Copeland, it's a pleasure to be here. I am Joy Miller Davis. These are my colleagues Ryan Smith and Leah Owens, and as stated, we are graduate students graduating in May, so we're really excited. But we're here because we are very passionate about end-of-life decisions because we are social workers. We call ourselves social workers even though we don't have the credential yet, but it's close, because we do believe in the empowerment of individuals, and self-determination is a key role in something that we advocate for our clients. Advances in healthcare have enabled people to live longer, even in the face of life-limiting conditions, than would have been possible only a short time ago. Such advances have the potential not only to increase survival time, but also to enhance quality of life. At the same time, the growing availability of life-sustaining treatments presents complex challenges for end-of-life care. Too often, however, individuals and families do not have the opportunity to consider, before a healthcare crisis occurs, either the physiological or psychosocial consequences of prolonging life. This approach to end-of-life decision-making is fueled in part by widespread reluctance to discuss either the limitations of curative and life-sustaining treatments or the realities and uncertainties of the dying process. Simultaneously, deep-seated social inequities pose barriers to individuals' and families' options for informed decision-making regarding the end of life. Rectifying such inequities and supporting clients' end-of-life decision-making constitute key roles for social workers, who provide services in palliative and hospice care programs throughout the healthcare continuum and across service delivery systems. Individuals and families contemplating end-of-life care face a broad range of decisions, each made within a specific cultural, legal, medical, psychosocial, and spiritual context. Such decisions can include where a person plans to spend the final months, weeks, or days before death. Supports and services to maximize independence, goals and desired strategies for alleviation of pain and other symptoms, and medical intervention like CPR and IV nutrition and hydration. Advanced care planning, which includes discussion of end-of-life care choices and documentation of those choices in advance directives, is a key strategy to maximize client self-determination in end-of-life decision-making. Ryan?
Good morning. So the National Association of Social Workers, which is the NASW, they uphold the social worker's role in a client's end-of-life decision-making processes, and they encourage further study, both within and beyond this profession, of the many complex issues associated with physician aid in dying. And the NASW supports legislation, policies, practices, programs, regulations, and research that promotes principles and goals related to a client's end-of-life decision-making and care, as well as creating and abiding by state policies and procedures that prevent these individuals or prevent abuse of these individuals in vulnerable situations. So the NASW feels like this interim study is a benefit to society just on its own because of the research and policy making involved. And as mentioned previously, there's 4 states that currently have successful Death with Dignity Acts: Oregon, Washington, Vermont, and California. And we hope to add Oklahoma to that at some point. And right now we're encouraged by the fact that in 2016 there's 17 other states considering death with dignity legislation, 17 other states that we found, showing that there is a general national movement on this idea.
So how does this apply to Oklahomans? As was mentioned earlier, cancer is the main reason that individuals choose to make their death with dignity decisions. Oklahoma itself is the 5th highest state in cancer mortality, so most Oklahomans with a cancer diagnosis will likely face this decision. The 2013, as a national overlook, there was an estimated 1.5 to 1.6 million patients receiving hospice care in the United States, and hospice patients themselves also face these end-of-life decisions. The one that really rang true to us was a Tulsa World editorial, and this really spoke to kind of Oklahoma's values that we thought we see in Oklahoma. And their statement was, it fits comfortably with the high value Oklahomans have for the authority of individuals to control their own lives and make their own decisions. And I think that as Oklahomans, we can all agree with that. One of the things that we want to talk about also to touch base is, like Gavin did, was to talk about the common parameters that surround the Death with Dignity Act. Again, you have to be 18 years of age or older, deemed mentally competent, and diagnosed with a terminal illness that will likely lead to death within 6 months. Patients must be able to self-administer and ingest the medication on their own, and 2 physicians must determine whether these criteria have been met. The main thing to remember is there's no exceptions to these criteria. These all have to be met, and it's just a safety parameter around the act so that people can't abuse it or use it in a way that people are afraid they might. That's about it. Yeah, we just wanted to present that information to you guys, and
Thank you.
thank you.
Well, I can just say, I just have to stop you all right there because you're way under your time limit, as everyone was. This is a topic everyone speaks very quickly. And I'm not sure, do you guys qualify as millennials?
Oh, thank you. Yes.
Okay. Well, I wasn't going to ask your ages, but I know as legislators, we're often thought that we leave that group out. And so I thank you. Okay. Thank you for taking your time to travel down here and share with us out of your schedules. Yes. Okay, Representative Copeland.
And congratulations on your upcoming
Yes.
graduation, too. That's great. Well, we've heard a lot of information, and I'm sure some of you got some questions. So if all the presenters are here, are there any questions that anybody has that we might ask the presenters for information that they gave
Can we
us?
do that? That's fine.
I have one to Gavin. There is a residency requirement in Oregon, correct? I mean, you can't just fly up to Oregon and say,
I need you to step up here and answer the mic. You can use that microphone.
Yes, there is a residency requirement. I believe it's 2 years.
2 years.
Is that not?
Brittany Maynard was probably 6 months or less than a year. She qualified.
Then I was wrong. Sorry.
But the bottom line is there is a residency requirement. You have to be there so long before. Okay.
She had to do something to establish residency.
Okay.
She had to count for it.
Okay.
You wanted to speak into the microphone. Did everyone understand that, or do we need Dr. Rettig to speak into the microphone on that?
I was just saying.
On the residency
Sure, it's less than
requirement?
2 years in terms of the residency requirement in Oregon. Brittany Maynard, that everybody referred to earlier, moved there and did something to establish residency. My recollection, it was in a 6 to 12 month range, but there was some requirement because she didn't live that long after she moved there.
I have one other question. You mentioned the fact that after ingesting the medicine, the length was 5 minutes to 34 hours. Why such a variation in the time it took for the actual death to occur?
So the reason for the variation has a lot to do with individual person's physiology. What is the nature of their condition? What is their underlying disease that is causing this? So oftentimes it's attributed to whether they were physiologically they were in good shape, whether how far the disease progression had actually gone. And so it's important to understand too that in terms of prognosis and these things, it's difficult to actually understand what is going to be happening in each individual case. And so there were concerns when the law was originally passed about, and that's why the statute was put in that you could do no additional measures to hasten. But it's really up to the individual. It's not up to the individual, the person's disease and the disease process that they have that can result in the variance between time of ingestion versus death.
Could you just sit right there? I have a question for you, too.
Sorry.
Okay, thank you. Did he answer your question,
Yes,
Representative?
yes.
My question is this. Euthanasia is illegal in the United States,
Yes.
But when we refer to the death penalty by drug injection, that is not considered euthanasia.
No, and the reason being, so euthanasia is intended to relieve the suffering of a dying patient. The intention for the death penalty is to cause the death of a person in order to pay for their crime. So that's where the distinction would be coming out.
And to follow up, what other countries? You said in the United States it's illegal, but we heard the reference to England.
So in many parts, many different places in Europe, euthanasia is legal. I think the most clear cut is in the Netherlands and Belgium as well. And so euthanasia as well as physician aid in dying is legal in Belgium for them to do. In Belgium, it's actually allowed also for pediatric patients under 12. So, and the reason being, at least for adults in Belgium, there's a really very good book by Margaret Batten that talks about this. And one of the things is, in the Netherlands, Belgium, they actually feel that the United States is on the slippery slope. And the reason being is they feel in their country they're so outgoing, they're individualistic, that they can help with their healthcare providers decide when it is their time to end their life. They said, you might not like our decisions or a person's decision, but it's brought out in the open. They go, unfortunately, in the United States, many of these decisions are done in the back rooms with families away from patients. And so the idea is they can bring themselves out to make them publicly available so you can know what this person's wishes are.
So help me understand the difference. I keep asking for a follow-up from somebody because it's me. Help me understand the difference in the language, the semantics, in death with dignity and physician-assisted suicide.
So that's been actually going through different evolutions. So it started out, oftentimes people would say physician-assisted suicide. But the reason why people have moved away from that, in a certain sense, is suicide is a moralized concept. We have to understand that not every culture in every country in every society actually views suicide as being morally wrong. All right? Many cultures in many different countries are actually indifferent to suicide. So, for instance, in Germany, they actually have suicide clubs, right, to help people who want to end their life with suicide. We should also remember that suicide, in the German language, there's 5 different words for suicide, 2 of them meaning honorable. And so the idea was suicide is such a moralized concept in the United States that we want to back away from it. And so that's where kind of the term physician aid in dying has been. All right? And so that's where they moved to using that terminology, that they're aiding in the patient's death. So did that answer your question?
I think it did. So we now talk about death with dignity instead of physician-assisted suicide or any other and we couple it with end-of-life issues.
We do, and the notion, not all end-of-life issues, but the notion of putting it on the death with dignity, and really the movement has been is, when you talk about physician aid in dying, which is kind of the coverall, the chapter heading for it, or physician-assisted suicide, we're focusing on the obligations of physicians to be doing this. We're talking about, is this consistent with the practice of medicine? What is not brought to light is the patient's dignity. All right. What is not brought to light is the individual person's autonomy to make a choice for themselves. So the notion of talking about death with dignity was kind of to move the focus back onto the patient. Why? Because in the top 3 choices for patients who follow this act is they want to preserve their dignity as they go through the dying process. So that's why you can see the evolution of the language, the terms that they use it there. What I would say is they were trying to become more articulate and accurate on what the focus is. Because again, physician-assisted suicide or physician aid in dying really focuses on what the physician's going to do or not going to do. Death with dignity puts the onus on why a patient is doing this. In many cases, it's because of right of self-determination. It's because of protecting and preserving their autonomy.
So often here in this building, we get involved in scope of practice for physicians. Yeah. And I'm just wondering, in Washington and Oregon, and now perhaps other states, 17, looking at it, do they work with medical schools at all? Or once these are passed, what type of doctors end up with this responsibility? And are they guided through their medical school? Any advanced training, I would think, because this has just recently come about.
Well, one of the things is they've set up such a structured process
law.
Yeah, they set the structured process, the law. The second thing is they've had so much input between their healthcare leaders informing patients about this law, or excuse me, physicians about this law, and the structured for process for doing it. If a physician is uncomfortable with this, they don't have to participate. But what I think that they're steering away from is making one specialty, like specifically always handling this. And so the idea is patients who are involved with many different end-of-life situations can make this decision. So I do believe that there is training and education there, but it's broad enough for scope of practice that any healthcare provider with long-term commitments to a patient and family can participate in it.
Just one more question.
Okay.
The drugs that are used, is it a special prescription? Is that in statute, or is it left up to the physicians? Or I'm just curious, you talked about the nausea and all, and I didn't know, since we have a problem with drugs here sometimes at end-of-life issues. How do they decide what cocktail they use?
It's really going on medical professionals.
Okay.
On saying what is best, what is the most comfortable for patients. There has been in the literature, I didn't mention today, some issues about different dosing for this, but really they're sticking with the standard for the barbiturate because it is going to work for the most amount of patients.
Does nobody else have any questions? Yes, do you have a question for any of the speakers?
No.
Okay.
I think one thing we didn't mention that is a little bit of an anachronism in the law as it is now. If a patient has an illness that is dependent on medical treatment, like diabetes or hypertension, a patient not only has the legal right to refuse treatment, we have the legal right and the ethical right to refuse treatment. There's no question that is firmly established in the law. It's a constitutional right to refuse treatment. So patients who have terminal illness that are dependent on treatment can effectively choose to end their life. On the other hand, if you have pancreatic cancer, as my father did, and pain medication doesn't relieve the suffering, the agony that patients can go through at the end of life, they have no legal right, because refusing treatment doesn't end their life. So again, this is really a question about options, about people having individual choices based on their culture, their religion, their personal beliefs in terms of end of life.
That just raised a question, though. When someone enters into hospice, and I've had relatives go into hospice, at that point, they've been on no medication, but then they do use morphine without a physician's care or anything. It's done in the home, and it's, prescribed and brought to you. But is that not a choice where they're making a choice to withhold water and food and use morphine to get them through their pain? And that's done in many states now, I know, with no oversight by the legal profession. Wouldn't you agree?
Well, there is oversight by the medical profession. A hospice does have a medical director who is supervising all of the hospice workers, including nurses, social workers, and so on. There's no question that refusing to eat or drink will eventually lead to end of life. But again, based on my experience with my mother and my father, my mother died very quickly, very peaceful death. It wasn't of her choosing, of course, because of an aneurysm. But I don't believe my father would have chosen to suffer for months, to be in and out of a hospital, and physicians who their very professional reason for being is to care for patients, is to provide compassionate care. They could not relieve his suffering. I, as his daughter, could not understand, in my naivety at that point in my life, well, why can't you comfort him? It's really, there are differences in the way disease progresses. One of the very first cases before any of the Death with Dignity Acts in the United States involved a physician named Timothy Quill. And the important thing about that, he had been treating a woman with ALS for 20 years. He knew her very well, and as most of you know, ALS is a degenerative illness that robs you of your ability to function in any way. Ultimately, you can't breathe. And she finally came to him. She had a husband, she had children. She said, I cannot go on like this. I can't do this to my family. You know, will you help me? And he considered it very seriously. But for a patient who had been his for 20 years, he finally said, yes, I will give you a prescription, but you have to tell your family. She did, and her whole family was with her at home when she died. You know, I think my father would have chosen that death, to die in an intensive care unit with physicians who could not end his suffering. So it's really about options. There's no question people can end their lives legally, but it's a very difficult process as opposed to one, and I would hope and I would think that in most of these cases the physician knows their patient. The patient trusts their physician. It's not a matter of going to a stranger and saying, will you give me a prescription? So I think it's a matter of allowing this decision to be made on a personal basis, on a case-by-case basis, between a physician and the patient.
Thank you. Did you want to?
I just wanted to address one point there where you're talking about hospice, you were talking about morphine, and you were talking about hydration and things like this. It's also important to remember that, particularly for morphine, recent studies have shown that the appropriate use of morphine does not hasten a patient's death. Patients with advanced cancer, what they found is that morphine is actually very good for helping their dyspnea or anxiety about the respirations, but it actually doesn't hasten their death. It's the underlying condition that's going there. In terms of hospice, when you're saying food and hydration, one of the things is dying is kind of like is a process similar to being born, and oftentimes your stomach shuts down. And if your stomach is shutting down and you are unable to digest, if you provide food and fluid to that patient and their stomach isn't working, that doesn't go anywhere. All right, that causes discomfort. And I think sometimes that I mention this to physicians all the time, that we get into this notion of a false dilemma. You either do everything or you do nothing. But that's not what hospice is. People will say, I want to keep fighting, and I always point out that palliative medicine and hospice, they're fighting. They're just fighting for something else. So instead of trying to fight for additional time, it's to maximize their symptoms and time that they have with their families. The other thing, as we were mentioning there about going home and dying, I should point out that actually voluntary stopping of eating and drinking is legal in all 50 states. A competent patient with a terminal disease always has the right to stop eating and drinking. And the reason why this is in the news lately, Diane Rehm, who was on NPR, her husband had ALS, I think it was, went to her physician because he wanted physician aid in dying, and they refused, and they felt powerless, even though he had known this physician his whole life. And so they felt that the only way he could achieve the death that he wanted was through the voluntary stopping of eating and drinking, which is a more of extreme way, and it does happen in different states. But again, it comes back to what choices are we offering patients. The Death with Dignity Act offers a patient, and it's not appropriate for all patients, but a patient has the choice if they feel consistent with their values of how they would like their life to end. Gives them, empowers them to do that. So.
Yeah,
Thank you. Representative
there's so many
Copeland?
things I'd like to say after hearing this discussion. For those of you who don't know, I'm a farmer and a rancher. That's what I am. I'm not a politician. I'm a farmer and a rancher. I went through. We go through this with animals all the time. I went through the same exercise with a cow that had an issue with having a calf. She died. I watched her not eat and not drink for 2 weeks and go from a beautiful animal to skin and bones before I took an action to stop it. Now, sure, not eating and drinking will end up in death, but why should they have to go through that? I mean, to me, that's inhumane. And a lot of times I see things that we do as farmers and ranchers, may seem inhumane to some people, but I sometimes think we treat it, but I digress. I get on another subject, but I want to go back to the ALS issue. If you'll look in your packet, those of you got it, there was a lady that sent me an email from Cache, Oklahoma, that had ALS. I'm not going to read it to you. You can read it. But if you read that and can honestly say you don't support something that gives a person the right to choose death with dignity, then I don't think you have a heart. I mean, I'm not. This whole I get accused of the euthanasia thing when some people that say that I'm proposing this legislation. You know, I don't think that's the case. But I've gotten letters. There's more in here, but this one is the one that really tugged at my heartstrings. And I had a neighbor that had ALS that I was mentioned earlier. Fortunately, he had a history of aneurysms in his family, and he had a aneurysm in his stomach, and they did surgery on him for the aneurysm, and he didn't make it through the surgery. And I'll believe to my dying day that the surgeon, they knew he had ALS, and I'm not going to say that the outcome was what they wanted, but I think the fact that he didn't make it through that surgery was a blessing to him and his family. So, I mean, that's the reason I'm proposing this legislation. I appreciate, I don't guess there's any other questions. I'm going to kind of end this. I appreciate everybody coming. I get a lot of emails from people saying, what can I do to help you? You know, if you have a senator or a House member in your district, contact them. Tell them what you believe. I've got a lot of letters from people all across the state. They don't need to call me and tell me they support this. They need to call their own representative and their own senator and say, you know, we think this is a good idea. This is going to have to be a groundswell of people out across the state that comes up and makes this happen. I won't make it happen up here. I just want to be the one that gets the information out and gets discussion started. So if there are no other questions, I want to thank everybody. Thank you, Madam Chairman, for being here and holding this. Thank everybody that helped me put it together. And if everybody that had a presentation at the meeting today would, I'd like copies of all of those so we can kind of put together a file. And if it ever does get down the road in legislation, I'll have something to go back on. So thank you all very much.
And I might just add, Representative Copeland, did everybody get a packet?
We have some more up here.
Okay, yeah, there's more there, and then leave your name or star it if we run out and you don't get one, because we can provide those for you. So thank you all. Okay, for those of you that this is between you and lunch, we're starting early. So, and I want to thank you for coming. And I want to introduce Representative Goodwin at this point. And Representative, would you give us an outline and introduce your guests, and we'll get started.
Thank you, Representative McDaniel. It is good to be here, and thank you all for traveling. Some of you I know have come from Tulsa. We appreciate you coming to Oklahoma City for what we believe to be a very important study as it relates to family caregiver support. We know that, speaking with Mr. Robertson and Ms. Love and Ms. Burke, that it's a huge issue all across the nation. I think everyone in this room has either had to be cared for, or there's someone that you know that is being cared for right now. So we want to talk about the ins and outs of that. How can we expand those services? What areas are underserved, and what collectively can we do to keep continuing the good progress that we have? So that's why we're here today. It's all about our loved ones and how we can best care for them. So what I want to do now is open it up with Mr. Lance Robertson. He's Director of Aging Services with the Department of Human Services. And really, I found to be just a wealth of information. And beyond that, beyond the numbers, my relationship with him, I found him to be someone who really cares about people, first and foremost. So I love that combination. And with that, I want to bring Mr. Robertson up. Thank you.
Thank you, Representative Goodwin.
Good morning, Representative McDaniel. Thank you for an opportunity to talk a little bit about family caregiving, and I'm very glad that Representative Goodwin has kind of picked up the torch and has decided this is an important issue. I know that for most of us in this room, it already has been a part of our lives, and if it hasn't been, it likely will be. So passing around a copy of my PowerPoint, which I'll go through very quickly. Do you advance? Oh, okay, very good. Thanks, Marcia. So really, again, when we're talking about caregivers, we're essentially, if you were to kind of define it quite broadly, we're talking about individuals who find themselves in an unpaid capacity caring for a loved one. Now, specific to the area of aging, of course, we're talking about older adults quite often who are the care recipients, but in so many cases now, of course, we're finding older and older caregivers themselves. So that's really kind of the focus of how we define caregivers and caregiving. And I know that Representative Goodwin last session authored House Bill 2384, which was the Oklahoma Caregiver Support Act. And I've already had a couple of questions, and I'm glad Mark's in the room from AARP, because I wanted to clarify the year prior was when Senate Bill 1536 passed, which was the CARE Act. And those are two different pieces of legislation, although both, the first one did pass. Representative Goodwin's did not make it through session, although both, again, are targeted at helping caregivers. So that's important to kind of clarify, because I know some folks have been confused about that. I also think it's kind of interesting to tie it in with the bill that was discussed earlier with Representative Copeland, because quite honestly, I think for most caregivers, you're going to find yourself dealing with an end-of-life issue unless circumstances get better, the health of the person you're caring for gets better. But for the field of aging, so often people are caring for individuals who will someday pass. So I think there's an honest connection between the discussion about palliative care and how, of course, that ties into the work that so many caregivers do. And unfortunately, so many of them are ill-prepared for what that means. And that's kind of what we're going to talk about today, but that's often the end result. So as Marcia has on that slide, that's sort of the general caregiver definition. Let's leave it right there for a second, Marcia. And I do know one thing that seems to unite everyone around this conversation, and of course you're going to hear from several other great people this morning, but again, this is such a universal topic that everyone someday will be impacted by, and I think it was the former First Lady Rosalind Carter who said that when it comes to caregiving, you either are a caregiver, you've been a caregiver, you will be a caregiver, or you're going to require care, and we're all going to fit into one or more of those categories. I myself have been a caregiver, and I know several others in the room as well, and there certainly may be a day where I get to practice that skill again, and someday I may be the person receiving care. So I think if it's not real for us at present, it will become real for all of us in the near future. So this slide that's up right now that you're looking at really is kind of a basic descriptor that talks about the profile of the average caregiver. And I think that's what Representative Goodwin wanted me to quickly lay the groundwork and talk about this morning. Really some pertinent data along with some key issues, and then just some general considerations. So you've got, again, on this slide, you'll see just the general profile. We know that 66% of caregivers right now are females. 37% not on there are actually caregivers who have children or grandchildren under 18 living with them as well. So that further compounds some of the challenges they are presented with each and every day. The length of the caregiving duty has often, research shows, extended beyond what was traditionally just a year or two, now to the average being 5.6 years of that caregiving duty. 6 out of 10 caregivers are employed. So that really creates I think, a unique and challenging dynamic for so many Oklahomans who are certainly balancing their own professional ambitions and career responsibilities with that critical duty at home as a caregiver. And many of them spend at least 20 hours a week or a half-time duty providing that care. Next slide, Marcia. Here are some Oklahoma statistics just to bring it home for us. We have, of course, you'll see the number of residents up there according to census. So we estimate around 350,000 Oklahomans are caregivers. That's about 9%. And those caregivers are each year providing 372 million hours of unpaid care. So if you were to actually attach a value to that, and of course most commonly when you're part of a caregiving conversation, people do, and I'm glad they do because there really is an economic impact to that. You're looking at, for Oklahoma, $7 billion of economic value for the care right now that is being paid or provided at no cost. Of course, we also have the dynamics in our state being a heavily rural state. A lot of tribal partners are involved in this, so Oklahoma is unique in that aspect. And I will say yet again a nod to the partnership with AARP that the Senate Bill 1536, the CARE Act, Oklahoma was the first state to actually pass that law, which I think really sent a clear indication nationally that Oklahoma is serious about doing all that we can for caregivers. So again, any conversation that makes the caregiver the focal point, I think is a real valuable conversation to have. Next slide, please. Go ahead and click through that if you don't mind, Marcia. I didn't realize it phased in like that. That wasn't me. Oh, if we can go back, sorry. You guys have copies too, so you kind of have the full PowerPoint in front of you. The other challenge I think we're having to really admit to is that within caregiving, all those experiences are very hard to pocket or define in a singular fashion. It's pretty incredible how we're talking about the length of experiences, what that journey may look like, the various roles that caregivers take on. And that's important to point out because as we struggle with how to help caregivers, it's not just a simple fix, or there's not a one-size-fits-all sort of answer. We know that research now also has confirmed that the average American woman will spend more time providing care to an aging loved one than she will being a mother. So that data now reflected on the bottom of that chart shows that you spend about 18 years, or in my case, for the child that won't go away, much longer being a parent. But then, of course, the caregiver role now exceeds that, and it's 19 years of service as, again, a care provider. That next slide focuses again on the economic side to this. I recognize, like we all do, that the reality is money talks, money shapes and drives a lot of conversations, and this is the thing nationally that people continue to talk on is how do we both acknowledge and then appreciate that economic value of what caregivers are doing across the country each and every day. So across the U.S., 40 million caregivers. You can see some of the numbers there. That bottom number is what's so critical, $470 billion of economic value. And again, we're going to talk in a couple of slides about what that really means. But to give some perspective to how much is $470 billion a year that's being provided in economic value from caregivers, you're talking about more than total Medicaid spending, more than total out-of-pocket spending on all health care, more than the sales of Walmart, more than the sales of the 4 largest U.S. tech companies, and it's about $1,500 for every person in the U.S. if you were to just try to kind of wrap your mind around the $470 billion. We know that for working caregivers, they lose about $185,000 in employment wages because of lost income from caregiving responsibilities, and that family caregivers are 2.5 times more likely to end up in poverty. Next slide, please, Marcia. Thank you. So this slide, which again in front of you, you will see an iceberg. Essentially what I think, again, is so important to appreciate is that so much of the health care that's being provided across the country is really being provided by informal caregivers. So as the iceberg analogy would attest, below the water surface is where most of that iceberg exists, and that's where a lot of the healthcare needs are provided at no cost and by family members, versus the thing that gets the most attention, which is what's above the water, and that's the formal healthcare system. There's also, I think, in our country this caregiver assumption, and I think that's not a bad thing. The assumption is as you get older and you begin to have needs that you're going to have some family member that is going to take care of you. Often that's either a spouse or a child. Again, we're kind of as a country built on that premise, and certainly in Oklahoma, with the Oklahoma standard, we understand and can relate to that. The real precious part of that conversation is how do we support caregivers so that they can do that. And unfortunately, as a country, we're not yet in a position to really claim that we've done that. So family caregiving today, again, is more complex, costly, stressful, and demanding than in any time in human history. So conversations like this are timely and valuable because we've got to be able to do something to really address some of these key issues. So to summarize those key issues, Marcia, next slide, please. Thank you. Again, the economic impact, we just referenced the $3.6 billion of unpaid care being provided in Oklahoma each day or each year by family caregivers, and to really kind of think about the impact that has on our healthcare system, the savings of people providing the care informally rather than that care having to be provided into an already stressed formal system. So that's worth appreciating. The impact, of course, on the health of the caregiver. That's been my focus over the many years I've done work in caregiving, is how do we replenish and take care of that caregiver? Because ultimately, as we know, and I think we're going to have, Grace is going to talk a little bit about it, we have a lot of caregivers who burn out even before the health of the person they're caring for fades. So often in Oklahoma, we're seeing a situation where not only one person is in physical peril, but a second person, that caregiver, often finds themselves in worsening shape because of that caregiving responsibility. The working caregiver, which we'll reference here in a moment, but my gosh, if 6 out of 10 caregivers are trying to hold down full-time jobs and do something meaningful in the workplace and balancing that with 20 hours a week as a caregiver, we know what kind of stress that can create. Making sure that they have access to good, timely information is important. We'll talk about that as well. And then, of course, another issue that is troubling is the ratio. We have now fewer and fewer caregivers available to care for a growing number of people in need. So again, it's not sustainable. And I would also reference that the National Academy of Sciences just released a report on caregiving called Families Caring for an Aging America. They released it last month, and it's outstanding in terms of just the data and the issues that they bring up and where we're headed as a country if we really can't get out in front of this a little better with policy, program support, etc. So speaking of policy and kind of what's happening, if you looked at the national landscape, this next slide talks about just some of the main things that are happening, again, at the national level. I kind of pulled out what I could see as kind of the dozen top things that are getting a lot of attention and play. Some of it, of course, would involve national policy change. Some of it would not. Some of it's much more localized in nature. But you can see here kind of the broad attack plan of how we better support caregivers. It's kind of all over the place, but if any of these things can really take off in its own measured way, certainly they could prove helpful. I know for that first item, we at DHS Aging Services are responsible for a couple of programs that support caregivers directly, and the largest of which is the National Family Caregivers Support Program, funded through the Old Americans Act. That's our responsibility, and we do what we can with very limited funding for that program. And then we also have a small kind of grant that supplements that work. Otherwise, that's really the only formal role we play for caregivers, although as technical assistance operators, we often provide a lot of Oklahoma families with guidance on kind of where to go to seek the sort of help they need. So you can again see from the original list of the 12 what's highlighted in blue, and talking with Representative Goodwin, seems to feel like kind of the four, if we were to piggyback off of the national conversation, there are sort of 4 different issues that may make the most sense in Oklahoma and would potentially be cost neutral, but might help us move the needle. So with the collaborative support of partners like AARP and many other entities that are interested in helping provide Oklahoma caregivers with support, maybe these are 4 areas just simply for discussion that Representative Goodwin and I have already sort of been discussing. So next slide, Marcia. If you look at that first one, better access to information, the state is involved in the development of a portal system that actually just yesterday there was a press release from the governor's office admonishing the work of the Human Services Cabinet for kind of a multi-agency agreement to put together a portal that will enable family caregivers to really have access to timely and accurate information on where to go. And so often with families who are struggling with caregiving, it really, acknowledging the fact that sometimes those caregiving situations just come up overnight, the real challenge is they just don't know where to start. They don't know where to go. They don't know who to turn to for help. So I think having a system that people can access at their convenience, while isn't a silver bullet, it will really help, because so many families then, starting from day one, can sort of feel like they're somewhat self-navigating this process, and that will allow them, I think, some more confidence and then the ability to kind of self-navigate. So you can see I've got a link up there for you. You can check out what's happening relative to that particular initiative. The issue around employers and how we can help Oklahoma employers appreciate best practices and how they can support working caregivers, I think is a real opportunity. And as we were talking about with Representative Goodwin, I think this can be you're not going to put mandates out there, and this is cost neutral, but if Oklahoma companies can stop and just recognize and appreciate how many caregivers they have in their own workforce and the impact that can have, They don't have to start from scratch on what they can do to build a supportive environment. The link there will take you to the brand new EEOC guidelines on what they suggest for employers to be most supportive of working caregivers. So in looking at that document, and it's rather hefty, it's a 14-page document that you'll grab when you go to that link. They have a lot of great suggestions that really for these companies just beg flexibility. They beg the ability to support that caregiver, particularly on a short-term basis, to get them over that hump until they get into a kind of a pattern that works for them and their family and the one they're caring for. So I think for a lot of employers, this will be encouraging information, and certainly I think something we can kind of land on as a way to positively impact Oklahoma caregivers. Next slide, Marcia. So the final two, Representative Goodwin and I had been talking about what's happening out in California, which of course has gotten a lot of attention relative to the caregiving resource centers that they've set up out there. Now, the state of California did invest in this. It's about a $3 million a year operation. We, of course, have, through the Aging Network right now in place, I think a system that can work if we can just continue to acknowledge the support that's needed there and what we can do to really focus on caregiver support. And I think if you go back and read Representative Goodwin's House Bill 2384, that was kind of the premise, I think, or tied to, at least in my mind, what she would like to do, focusing particularly on folks that are low income or somewhat disadvantaged who are confronted with a caregiver situation, which really creates a very fragile situation. So the link there takes you out to the California example, again, just as resource information to share with you today. And then finally, the educational piece is so critical because for Oklahomans, they really don't want to sit down and have this conversation in advance. It's hard to have enough advanced planning conversations to properly equip an Oklahoma family, which means usually when they contact us, the situation's pretty challenging. So I think, again, some proactive and preemptive support on the educational side is always going to pay dividends. I think about recently what we've done in kind of refurbishing the Alzheimer's state plan, the behavioral health state plan, which is forthcoming for approval. A couple of recent examples of some statewide planning that's happening in a specific area, but the common denominator is caregiving, because everybody impacted by these plans, ultimately, you're going to define them as a caregiver. So let's make sure that on the educational front, we put energy into supporting that, doing a whole lot more so that people, again, feel supported, they know who to turn to, and they know what resources are available to them. And I think, Marcia, that's my last slide. So thank you again for the time. Thank you, Representative Goodwin, for your support of what is ultimately a very important issue, and that's supporting Oklahoma caregivers.
Hold on, stay right there.
Yes, ma'am.
Director Robertson. What we're going to do is, while we switch out slides with Ms. Love, I think you have a PowerPoint that we can give. We can actually, since I have no committee members here to ask questions, you just can get me, and then if any of you here have questions about the presentation, we can discuss that now. Okay. So you get me first.
All right.
And the first thing I would just say regarding California, when you think $3 million and then you divide by the population, you're going to get about $3 in your budget. I can see that. So don't say it only costs $3 million when this comes up, because it is a valuable tool, especially with so many rural people in our state. I think the technology today to help reach them is just so critical. Also, so don't say $3 million in California, or you might get $3 in Oklahoma's budget for this. And I think it's very important, because you're right. When it happens at 2 a.m. and you're looking for depends and you don't know what to do and you need a hospital bed, a lot of people now, if nothing else, can get to a library and find out if they don't have 211 or your line available. What I would ask is this: in a lot of instances, I see legal questions come about, because so often when you become the caretaker, there's bills to pay, there's guardianship, there's all that. On your website, do you reflect that, or is there any legal aid or any advice given to people? Because so often I know they start doing things and then realize when it's time to have that person sign the taxes or all the other myriad of things, they end up in our legal system. Do you guide them any place or give them the idea that they need to see an attorney to do things legally?
Sure, absolutely. And, Oklahoma's fortunate because we have a single legal services aid developer statewide. So that resource would be available to a lot of Oklahomans with questions. We also have in our division the legal services developer for the state, Shirley Cox, who who is a good resource. And I think so often for individuals that have those types of questions, these individuals I just referenced, they might not be able to handhold and walk them through the entire process, but they can at least help them acclimate to what's ahead, what resources to look for, potential costs, etc.
Does anyone else have any questions or comments? Representative Goodwin?
I thought the point that you made that the caregivers are 2.5 times more likely to end in poverty. Could you kind of address that?
Sure, absolutely. The research, I think, really fleshes out the reality that for so many caregivers who go into a caregiving situation unprepared, I think like many of us would be if you got a phone call tonight that said you're now going to care for your mom, no advanced planning really has occurred, so people try to shoehorn that into often already tight budgets. And then I think for so many working caregivers, that lost wage figure we referenced, the $185,000 they've lost over the course of their working career, that equates to a lot of Oklahoma dollars. So I think for so many people who really in a state that's recognized with such high poverty rates, you're looking at so many fragile situations that from the very beginning put not only that person receiving the care, but that person providing the care in health peril as well as fiscal peril potentially. So again, that's the importance of that advanced education and some advanced planning to the extent possible.
I had one other question. I recently had a friend whose husband went in for some surgery at 88 and developed delusional dementia, non-reversible. And she said in 4 months they spent over $100,000 because it's psychiatric care full-time in a lockup situation, which they never anticipated. Professionals, she at 85 is still working, but it's just something you never anticipate.
Right.
And the cost is just phenomenal. They'll spend $500,000 easily this year. He will never return home. He will always have to be in a locked facility now. And I know this is probably happening more and more as we age, live longer, and have dementia and Alzheimer's. But is the information center you have set up for not just but a whole sliding scale of people on income levels? Because at one moment you can be solvent, and within a very short time you're mortgaging a home.
Right, absolutely.
And so is that there on the website? I haven't looked, to be honest
It will
with
be.
you.
It will be. And to some degree it already is, but I think now that there's a statewide collective body kind of putting this together, you're going to see the growth of what I hope will be just an outstanding system. That, to answer your question, yes, will also reflect private pay alternatives, as well as program options for those who maybe qualify for some sort of assistance. The best example is Medicaid. So really it would cover the entire waterfront on what options and services are available. And because every caregiver situation is slightly unique, you often have to case manage or kind of walk that family through it. And I think this will be a good tool to really help at least start those conversations in a meaningful and effective way.
Now, is this a result of the legislation that was passed last year that you're developing this?
Actually, the legislation you may be referencing is some years old, 4 or 5 years old maybe. But then this interoperability multi-agency group that's putting all this together is not necessarily a legislatively driven charge, I don't believe, Mark. Executive order. So there it is. Thank you. That's right. There was an executive order. I can't remember if it was last year or the year before, but we had actually in DHS Aging Services spent some years developing and kind of birthing the concept, getting some interagency partnerships put into place, and then from there we're grateful that, particularly for sustainability reasons, that this multi-agency group's kind of picking it up and running with it.
Okay. Mark, did you want to say anything or add anything? You can you have to introduce yourself in the microphone. Sorry, then I put you on the spot.
I'm Mark.
Go on down there.
Yes, I'm Mark Jones. I'm the Director of Community Living Support Services at the Department of Human Services. The Governor's executive order, which was a result of and followed the Governor's executive order on the waiting list for people with developmental disabilities, created the Executive Council, which includes all of the state agencies in under Dr. Klein's responsibility, as well as higher education as well. And the portal that Lance was talking about came out of the work of that group. They're continuing to marshal it through both the funding and development process. And so it was not independent legislation, but an act of the governor.
Hold on, you don't get away so easily here. I was at a meeting last week, and I was told the waiting list is now up to 7,500. Could that be right?
Yes, it is. We've had 2 consecutive years where we've not had appropriated funding to address the waiting list. And so we've had to address the waiting list through attrition of people who are already in the system. There's about 5,500 people in community services statewide. And some of the people that get services are emergency situations, both for children and for adults. Mm-hmm. And so they move up to the top of the list, and including a number of the children with developmental disabilities that come into state custody satisfy that emergency criterion as well. And so we don't really make a whole lot of headway on the waiting list unless and until we get special appropriations to work those. We had 3 consecutive years of $1 million each year, and in that situation we were able to knock out 300 at a time.
To that, now I'm getting older myself. I'm 60, almost 68, but it seemed to me when I was first elected in 2004, we had 3,000 on the waiting list. Would that be about right? Yeah. And I know this isn't just aging, but it's caregiving, family caregiving for the spectrum from birth to death. And so I just wanted to make sure I left with that in my review mirror. We've jumped from 3,000 to over 7,000 now on that list. Thank you.
You're welcome.
Mm-hmm. Oh, Representative Goodwin, go ahead.
Mr. Robertson, as we had discussed in previous months, can you share the district that I represent, right, I think is underserved in terms of services, in terms of access. Do you have any numbers as it relates to, in terms of demographics, who is being helped in terms of, in particular, African Americans? And if there is a gap, how do we close that gap in terms of services? These folks having access to the services that are available, or perhaps, as we had discussed, setting up satellites in terms of something that's not expensive, but it's just a matter of us being a little more creative with the few resources we have, as we've discussed.
And I think what we talked about was really being able to better support existing providers and the network that's in place. We, particularly through the National Family Caregiver Support Program, we do have targeting requirements. So we naturally, first and foremost, do target individuals who are lower income, minority populations, rural, et cetera. There's a small list of our targeting that we really focus on relative just to the National Family Caregiver Support Program. Now, more generally, when you look at caregiver support across all program areas, I do think that so often, if you're talking about Medicaid, you are talking about a low-income population. If you're talking about where the higher density of caregivers are often found, mm-hmm. it's in lower-income populations. So there's a real commonality across that conversation. And so often, as you and I've talked about your district, I think probably, although the statistics would be probably easier to dig up, but I think within your district you probably have a higher ratio of caregivers than maybe some other representatives might be able to argue. I can't say that factually, but that would be my suspicion.
And with in the rural areas, right, access is also an issue in terms of distance. What are you finding? What are some of the concerns that you hear in terms of the rural populations?
Well, and healthcare being the driver of so many of those needs, we all recognize that that's the biggest challenge that an Oklahoman living out in a rural part of the state is going to encounter, and that is how can I affordably gain access to healthcare? And maybe something like telemedicine and some of the things that are kind of on the frontier could help. I don't know. I'm not an expert in that area, but I do know that that's what's causing so many older Oklahomans to have to move into an urban area now, is simply that access to health care. And unfortunately, that results in the drying up of parts of Oklahoma. It also means that those providers that maybe were out there originally are having to rethink their whole business model, because so many of the people they had previously served are now having to move to urban areas for more intensive and specialized types of care.
I have a follow-up on that last
Yes, ma'am.
question, and that is, as they do move to rural areas to receive the care, whether it's dialysis or whatever, as hospitals are closing and becoming emergency clinics in rural Oklahoma, it would seem to me that that takes away the family caregiver in many cases too, because they may not be able to relocate. So it may not be a son or daughter caring for an aging person in their home, but in a facility in a more urban area. Are we seeing that?
I'm sure we probably are, at least anecdotally. I don't know if we necessarily have research to back that up, but certainly there are going to be situations where families feel like their only option would then be institutionalization in some sort of long-term care facility. And of course, we have the former state long-term care ombudsman in the room with us, and her previous team and that current team now really puts a focus on making sure that quality of care is there for long-term care residents. But to your question, yes, I would suspect that for, well, like Representative Copeland, who is a legislator that is a farmer and rancher, if he were in a caregiving situation, I don't know if he could necessarily set his farming and ranch responsibilities aside and then move to an urban area. He may have to look at placing a loved one, spouse, whoever, in a long-term care facility.
One other issue that just came to my mind, and that is in-home care. Mm-hmm. So oftentimes we deal with people coming in once or twice a week for bathing or medications and things. I would suspect there's less of that in the rural areas available as well.
Well,
in-home care.
Sure. We of course, I can only reference what we do through our Medicaid work, our waiver work. We do struggle sometimes to have a sufficient provider network out in rural parts of the state, just because of the economic ability for them to make a profit out in rural parts of the state. So in some respects, you're right. That might also weaken our ability to care for Oklahomans rurally.
Okay. Thank you. You can introduce you next.
Mr. Robertson, as always, thank you.
Thank you. Appreciate
so much. Great working with you.
All right. Thank you.
Want to, next on the agenda is Miss Margaret Love, who is well known for her advocacy of seniors for decades, and thought we could not have an interim study on family caregiver support without having Miss Love here. Her work, as we say, boots on the ground. Folks are actually in the homes, knocking on doors, trying to see who needs care. I know as recently as this morning, she was speaking with someone who's about to have the bed taken out of the home, and somebody actually needs that bed and has had that bed for some 8 months, and they're going to call Miss Love, and she's going to get help. But I just wanted to have her come and speak to the need for expanding care, how we might do that, the population that you deal with, and thank you for coming all the way from Tulsa. Miss Margaret Love.
Welcome, Miss Love.
Thank you. Thank you, Representative Goodwin. You put a lot of emphasis on that decade. I kind of wonder about that. I want to don't you take that any further. I want to thank Lance for coming. Lance has been working with the Asian population. I've worked with him for years. He is most certainly knowledgeable and very open with information, and I always want to thank him for that. Why I came was because I want to talk about caregivers, and God, by the way, my PowerPoint was not compatible with her machine. So anyway, we will move on.
We do have the handouts, so
yes.
Did we get the handouts? Mm-hmm. Okay. All right. Thank you.
I want to talk about caregivers and some of the disadvantages, and just inform you of some of the things that go on with the caregivers. I've spent 29 years in home-based programs, and I have worked with all types of people and every situation. But there are two types of caregivers for older adults and disabled persons. There's one that we call the informal caregiver, and these are the people, mostly family members, who are unpaid. They don't get paid for the services that they do. And then we have the formal caregiver where we get paid services through some of the programs like the Advantage program, other programs that we have in the community that works for pay. I want to talk to you Lance gave you some data, and I just want to share, we're not too far off from what he was saying, but who are Oklahoma caregivers? There are 370,000 informal caregivers in the state of Oklahoma, providing about 400 million hours of caregiver services. There are 82,300 grandparents living with grandchildren in Oklahoma, and I am one of those grandparents raising a grandchild. 850,000 people with individual developmental disabilities live with caregivers age 60 plus. And I found that out as I was working in the community, that there was a lot of dealing with the elderly population. There were a lot of grown children in the home that was disabled, and it was kind of like the hidden group that nobody knew about. And then there's 65.7 million, or 29% of the U.S. adult population, care for someone who is ill, disabled, or aged. Older adults provide an average of 31 hours per week of care, while middle-aged adults provide an average of 19 hours per week. So who are care recipients? Of older adults with disabilities, you receive long-term care services and support in their home. 66% get all of their care from family care members. 26% get their care from a combination of family and paid caregivers. So that's about 90% of care recipients that involve the family members. And then there's 9% who receive their care from paid caregivers alone. Where Oklahoma caregivers call to arrange help in the home for elderly relatives or friends, we have a system on how we ask for services or how we know about services. So staff, there's about 13.4% who can actually navigate the system to see where and receive services from that. And then some of them, 22.5%, get it from relative or friends. Medical support, probably 20.7%. Religious support, probably 1%. And basically, when you deal with the African American population, the church is our resource. We usually go to the church for pretty much everything. Area Agency on Aging, 0.6%. People in my city, when we talk about the Area Agency on Aging, they say INCOG, instead of saying Area Agency on Aging, and they want to say, now, what is INCOG? It doesn't fit. So they don't know that that's where we go for the resources that we're looking for. There was a 1.3%, and then there's 41.2% who don't know how to navigate the system. And the typical African American caregiver, I want to kind of focus on that because we're the most disadvantaged. A caregiver is a 44-year-old female caring for one adult, a 66-year-old female relative who needs care because of a long-term physical condition. She's been a caregiver for 4.2 years, spending 26.8 hours a week, helping with 1.8 ADLs, and that's the personal care, 4.2 IADLs, which is a housekeeping and other needs, and medical or nursing tasks. She moved away from ADLs to IADLs to the medical and the nursing tasks. She is the sole unpaid care provider for her loved one and provides care without the assistance of paid help. She is likely a multi-generational caregiver, meaning that she probably has some children in the home. And I kind of want to tell you a little story. There's a lady right now that I'm dealing with who had her parents, both her mother and father. She was 48, I believe was her age, caring for her parents, 10-year-old daughter that she was not able to give any time to. Well, the parents passed away eventually. Over the years, they passed away. The 10-year-old did not get the attention that she needed. And at this point, she's reading on a second grade level. So again, when you try to multitask and have all of these issues, it's really hard for you to keep all of your bases covered. Let's move on. African American caregiver, she's employed. She works 32.9 hours per week. She is not married. She is a high school graduate or has taken some college courses, no degree. The average combined household income is about $37,700, which is below the median income for caregivers across all backgrounds. And we're going to talk about the perceived needs of African American caregivers of elders with dementia. Barriers cited by African American caregivers in an Oklahoma City study, and this happened back in 2001, I believe, at the Donald W. Jones Geriatric Institute. I used to attend those fellows every year. But this was a study, and it talked about the barriers cited by African American caregivers in Oklahoma City study. There was lack of awareness of available services. And then there was scarcity of support groups that met in predominantly African American communities. In my community, there's no support groups. I worked for the Alzheimer's Association the last 7 years of my life, and we're out on the 80th Street, and North Tulsa is about 10 miles from that. So that means when it comes to services, we can't come together because they don't have the transportation or anything to get to the place where the services are held. Also, when you look at I also worked for the Life Senior Services for about 17 years. We are now in North Tulsa as an adult day center, but it's still the services that's needed. We have to go south to get those services. So we do have a problem with the availability of actually getting to the services. And then there's negative experience with formal caregivers. Historically, that has always been a problem for African American because of the situations that happened years ago. It still hangs in our head. Oklahoma City Caregiver Study recommendations. It talked about having seminars in the churches, and this came from that study with the Donald W. Jones Geriatric Institute. I think Dr. Bernard was over there at that time, if you remember. Seminars in the churches, these were some recommendations. Senior centers, we have one senior center located in North Tulsa, and it's really full. I go up there quite often because I am a senior citizen, and I kind of go in and just see what's going on, and I really enjoy it. It's really good, and it is most certainly a place where you can get information. That if we had the information available, that would be one of the services we could use to distribute our information. And then we have community centers could be a place that we could have. We don't have a community center in the minority neighborhoods, so we're kind of lacking for the services that we need to come our way. It hasn't been there, just haven't been there. Community education, and I know Lance talked about education, in sites such as public libraries, businesses in minority neighborhoods. So information can go out everywhere, and you can have a person that could come talk about the information. I'm a person that I have to look at you and talk, and then sometimes we're everywhere. So if we could get that information into the people by any means necessary, it can happen. We could run public service announcements in minority newspapers and on radio stations with large minority followings. And we can use layman terms and educational materials. Early in my career, I'd finished college and was really trying to use the words, didn't match the people that I was serving. So I had to come back down and use words that they could understand. And so layman term information, to me, I started using it wherever I go because it's important that people understand what you're trying to say. And have support groups in predominantly African American neighborhoods. That may be something that's coming up, Grace, something that you're working on. But again, this has not happened in our community, that we had the infrastructure to use the services that is allocated for us. Serving African American families, there are 4 key actions Oklahoma can take when developing successful African American outreach support programs. Provide culturally appropriate information on caregiving. Every culture is different. I wish we could all come in and be in the same basket and be the same thing, but we kind of like a salad. We have tomatoes and oranges and everything, and we want in that salad. So again, being culturally, just making sure that you're culturally appropriate with the information. I teach cultural diversity. I teach it all the time. Just on how to talk, how to not let our biases come in and take over things that we feel is best. Instead of listening, we're telling. So there's so many things that we could do. We could increase awareness through community outreach, education, and networking. And we could also provide access to resources by using accessible stations and persons knowledgeable of African American communities. Most of the people that come in our community are not knowledgeable. They want to talk to the minister. Actually, the minister is not the one that won the community, it's his secretary. So you miss the folks when you start talking to the ministers. They don't give you that type of information that you need. Support caregivers by developing caregiver services in the community, such as support group and trainings. So you want to say, why address outreach for African American communities? African Americans experience higher rates of chronic diseases, such as high blood pressure, heart disease, diabetes, dementia, and related complications. Culturally proficient care for African Americans is limited in communities, resulting in general mistrust of formal care providers. Lack of awareness, resulting in late use of services. Sometimes we work with people who, at the very end, they decide to go to the doctor, and sometimes not then, because of the lack of an awareness of services that's there for them. Lack of awareness resulting in late use of services, limiting their effectiveness and increasing cost. Every time that we don't get to the doctor the time we should, we can also increase the cost of going, because we usually have stage 4 cancer rather than stage 1. We don't actually take advantage of that. And lack of awareness of Area Agency on Aging information and referral services in our community. I said we call it INCOG in Tulsa, and actually it's the Area Agency on Aging. Policy and agency recommendations. Add caregiver assessment to all community long-term care services. Caregivers sorely need their own support services and the flexibility to accommodate their busy lifestyle. So adding a caregiver assessment would be a great thing to add, because while you're in the home taking care of the client, the person with the problem, they also can be evaluated and done an assessment on, and you would be surprised of what you find as far as the caregivers and their level of stress and other health issues that go along with that. You could build a presence in minority communities, train local organizations to provide support groups, caregiver trainings, and respite services. We don't do a lot of caregiver training, but we talk about the client. But as far as caregiver training, working with that caregiver, letting her know when her stress level get too high. One of the things, I teach at one of the universities, and I teach case management. And one of the things I found out that caregivers pass away at a higher rate than the person who have the disease. I've seen it happen, where this person is gone, and we still have to put that person in a nursing home. But with a little help and a little training, they can be better caregivers. And develop a family caregiver council to focus on caregiver needs and make recommendations to agencies as needed. Thank you.
Don't go away.
Oh.
So I'm going to take my position and use it now to get to ask the first question. So first of all, thank you so much for the recommendations. I've always told my kids and family, don't bring me a problem if you don't have a solution.
Bring me a solution.
And you did that very well. And so I'll let Director Robertson off the hook a little bit, and I'm sure that since those 2001 results came out, he has worked on those and improved a bit. Wouldn't you agree, Representative Robertson? I mean, because the 2001 study gave some good points, and
yes.
To his credit, he was not there when that
right,
came out.
He was not.
So he stepped in, and we still can't figure out area agency for aging on the computer or the phone book, but we're working on that.
We're working. Thank
How to
you.
find them faster. It does start with an A, but that you've hit the nail on the head with me, as I can never figure out who you're going to call,
Yes.
and how can you find your way through the website to Area Agency on Aging. I belong to a senior center in Tulsa too. I'm over at Eastside Christian, but I wish everyone had access, and without transportation, so often they just can't get to the centers, and so we're a small fraction of the population that need us the most.
Mm-hmm.
Have you noticed that I know your center used to meet at the old PSO building there at the corner of Pine and Peoria.
We still do. They still do.
Oh my gosh, that's such that little old concrete building. Okay.
And they are really crunched in there for sure.
Absolutely not an appropriate site for you guys. But with that being said, the camaraderie that takes place at those centers is just a hidden secret in so many cases of the people that need it. And I don't know if you found this, but our fragile can't go there, because if they go there and something happens, there's a liability issue in the case of mine.
Exactly.
And so I just applaud you on this. This is great. I see no reason we can't do this. The beauty of this is you haven't put dollar signs to it. So with handshakes and
You heard that, didn't you?
some other things at our fingertips now, we should be able to accomplish much of this, it would seem to me. So thank you for your service to Tulsa community, and
Thank you.
you need to stick around and help us see this through. So thank you. And Representative Goodwin?
I was going to say specifically, we were really mindful of the fiscal impact, and we thought it would be really minimal.
Totally.
And we see this as totally doable, and we do need your help. I know you provided for some of the churches. What do you think about, and I know we have a representative with Morton here, and she'll speak to that very briefly. But do you see any other outlets? We certainly were talking about Morton, maybe some of the higher ed facilities that are in the north.
I can, and thank you. I would like to speak to that. We have Langston University sitting in the middle of my community, and actually I'm an adjunct professor there. So again, that would be an outlet. I taught in the nursing department. Of course, I'm not a nurse for a while, but again, I have worked there, and that would be an option for us to get a satellite. And my thinking is crazy, but again, it works sometime. We can get a satellite where there would be a person and people can come, because it's about, there's the, I know, Grace, you know where the Morton, and you also know where Jordan Plaza. And I think these are some services. It's two buildings sitting right in less than a mile away from that college. So these are areas, when you think about doing something, you have to look at what other options, and that's one that come to my mind when I thought about making this reality.
Does anyone in the audience have any questions? We have time if you do of Ms. Love. Well, if not, thank you. Thank you again for your service, and thank you for sharing this. And I think this is doable, at least in our community. I can't speak for statewide, but certainly in the Tulsa metropolitan area, we have a lot of work to do. We can do it. Thank you. Okay.
Thank you, Ms. Love. Appreciate you pairing the paper with people. It's another thing to just drop off pamphlets and literature, but when you say let's have a person with that information, that's really, really important. Appreciate that. Also, I've had the pleasure of speaking with over the months Miss Grace Burke. I love that. First of all, they're doing something at the Morton Clinic. They just received a grant, a caregiver grant, and I wanted her to come speak to that. And what plans do you have, and how did you get the grant? And thank you for traveling here and sharing.
Thank you so much for inviting me. I do want to talk about the grant. I do want to add a little bit of content about caregivers for just a minute. I'm not going to mention statistics. You guys covered that really, really well. The interesting thing is that, Margaret, you mentioned a certain number of caregivers in Oklahoma, and Lance, you did as well, and I found another number. And the interesting thing about that is that most people don't identify themselves as being caregivers. They just don't think they are. And so when we ask people, are you a caregiver? They say no. The definition of caregiver is just random. It's just out there. When I began working with older folks and their families more than 20 years ago, I was not a caregiver. I really wasn't. I couldn't have been defined as one. But now my mom is 87 and I am. And when I started to be a caregiver, I was just calling her to make sure she was okay and everything was good and she was doing fine. That's caregiving. It may not be real stressful at that time, but the second you call and she goes, I really think I need some help, that's when caregiving becomes a lot more stressful. So it's a building thing for a lot of people. Now, the example that you gave where somebody was doing pretty well and then all of a sudden had an incident, that occurs as well, of course, where somebody's doing great and then all of a sudden they've got some kind of incident or something's happened. But traditionally, people grow into needing care and people grow into being caregivers. And you know, we're not built with that information. It's not in us. We weren't born with the information about being a caregiver. And so a lot of folks, as they slowly go into caregiving, they're doing great in the beginning, and then they don't know where to go. They don't know where the resources are. They don't know how to make it better. They don't know who to call. And even if there's things on websites, they may not even know that that's what they should do. Because again, what are they not defining themselves as? A caregiver. So I think we first have to teach people that caregiving's okay, that you are one and it's good, but you're not built with the knowledge to make it happen. I've been working with caregivers forever and learned how to do that and have this innate ability. Some people just have it, but then it's my mom, and my innate ability goes right out the window when it's my mom. I can't give myself the same advice I give other people because it's such a personal thing. So let me just go through, make sure, we all talked about juggling families and jobs and caregiving, and the average number of years these days is growing and growing. Who would have suspected that my mom would live to 87? She said that a couple weeks ago. She had actually a pulmonary embolism, which we didn't expect because she's healthy as a horse. And she looked at us and said, I know I'm really old, but I'm not ready to go yet. We said, we're not ready for you to leave, and we're going to make everything happen. She's actually home again, except last night we were at the ER all night with some other issues. But, it really is a cascading thing, and people need support. People need support, and they can't just get support from their own friends and family. They've got to get support from the state, from organized businesses or groups or resource centers where they can go, where they know that support is available. And we have to get the word out. Having it's not doing it. Doing it is doing it. Making sure everybody knows about it so they can access it. That's what it's really about. Okay, so first you go, you do their shopping, and then you drive them to appointments, and then you start cooking their meals, and then you start managing their meds, and then you start providing treatments if they've got chronic health conditions, and then you start bathing them and dressing them. And if you're a son who has a mom, okay, so you're not bathing them and dressing them. You're trying to figure out who is going to do that. By the time you go through the process of providing more and more care, you're depressed, the caregiver. The caregivee is depressed as well, which is just adding more because they're losing their abilities and they don't want to. My mom is of the great generation, and she refuses all care. She doesn't want anybody to help her. I'm involved in a research grant in OU in Tulsa called Aging in Place, and we're trying to figure out, why does the great generation turn down services that will give them exactly what they want, and that's to stay home? But they do. They don't want the services. Now, there are pockets of people who do, but my mom's walking with a walker, can barely make it to the bathroom, want physical therapy. Absolutely not. That person's not coming to my home. I'm fine. And does she need physical therapy? Yes, she does. But she won't take it. And we're trying to figure out why the great generation turns down services. Let's see. Okay, so they develop chronic stress. Caregivers do. They don't eat well. They don't take care of themselves. And the interesting thing about chronic stress is that health studies that measure stress use caregivers as their example, of chronic stress. Caregivers develop
Could you say that again?
Yes, I'll actually read it. Caregiving fits the formula for chronic stress so well that it's used as a model for studying the health effects of stress. Even if you love your mom, even if you have systems built in, it is so stressful to try to figure out, how am I going to go do her shopping, my shopping, take care of my kids, my dogs, my house, her house, make her meals my meals. How am I going to take her to the doctor, me to the doctor, me exercise, her exercise? How is all of that going to happen? And it's very stressful to try to figure it out. And so guess what caregivers do? They give it to the person they care for, and they don't give it to themselves. So the person they care for goes to the doctor, eats really well, gets their exercise, goes outside, and the caregiver doesn't. And they get less and less healthy. Most caregivers start out healthier than the person they're taking care of. This is the only statistic. 70% of all caregivers over 70 die before the person they take care of. And that's because they don't take care of themselves. If you look at all caregivers, including caregivers of young developmental disabilities and things, the statistic I see is 30%. But if you're over 70, taking care of somebody else, you die before they do, 70% of the time. And then, where do they go? Long-term care, because there's nobody else to take care of them. Because the caregiver didn't know enough to take care of themselves. The first thing I say to a caregiver when I meet them and we're talking about everything is, you have to be healthier than the person you take care of. You have to. If you're not, you can't take care of them. So your main job to take care of them is to take care of yourself. But caregivers feel guilty about taking care of themselves, spending time on them rather than the one they're taking care of. And so they're much less likely to actually take that advice. I had a lady at an Alzheimer's conference. She came up to me and said, I want to write a book. I'm like, oh, yay. She's like, will you write it with me? I'm like, yeah, because I deal with caregivers. I could write a book. Okay, let's write a book. What are we going to write a book about? She said, I quit my entire life for 10 years to take care of my mom who had Alzheimer's disease, and now I don't have a life. I have nothing now. She was in her 50s. I don't have any friends. I don't have a job. I don't have any skills because I haven't worked for 10 years as a paid person. And she said, I need to write a book to teach people not to do that. And we do. We need to teach people to take care of themselves, make sure they still have a life. And people are not inherently going to do that. They need help understanding that. They need help understanding that stress is normal, but doesn't have to be as stressful. Okay. All right. So 80% of caregivers who identify themselves as caregivers surveyed expressed that they needed more help and information. 80%. Okay? Those are people who know they're caregivers. The rest don't, and they don't ask for help, and they don't know where to go for it, and they don't know what to call it. So I'm here from Morton Comprehensive Health Services. We're a federally qualified community health center in North Tulsa and in other places in the Tulsa area as well, but our main clinic is in North Tulsa. And I was recently honored to be given a grant by the INCOG, Area Agency on Aging, in Creek, Tulsa, and Osage counties. And it's a caregiver grant. And it's Caregiver Information and Education Services. Now, it's small. It's $43,000 a year. And it only covers 3/4 of a person. But it is more than we've had in the past. To be able to get out there and provide services in all the places that Margaret mentioned, in workplaces, in churches, in community centers, that's our goal. The grant, as I wrote it, was for us to go to the people. Go to the people that don't have the services right now. So the grant specifies that we have to serve those that are underserved. That's what Morton does anyway. as a health center, and that's our mission. And it seemed to be a perfect fit for us to get out there and help those caregivers in our area in North Tulsa, and then in some of the other areas in a lot of different ways. I now have my staff person is trained in Tai Chi, so we'll be offering Tai Chi for arthritis in our community at Morton, starting really soon, I hope. That Tai Chi training came actually through another INCOG grant through DHS, so we were able to kind of piggyback on their grant to become trained. I recently got a degree in healthcare administration. My very last class that I took was in nonprofit business management. We had to create a business, a nonprofit business, and mine was, believe it or not, called Caregiver Cafe. And I want to bring it to the people. I want a place where people know where I'm going to be and they can come to me. I want, actually, with a lot more money, to have an activity person to keep the person that you're taking care of kind of busy on the side, so caregivers can sit and have coffee and talk and chat. And, you know, there's a place for educational stuff. Let me teach this. Let me give you pointers. There's also a place for just really informally having somebody to talk to, getting to know other people in the community who are having the same issues, so you can have somebody you can identify with, and then sharing resources. What's out there? What's already out there? What do we need? Where can we go to reach more people? Part of the grant is to get into workplaces, into the rural areas, into the churches and the community centers out there to provide caregiving assistance, information and education to caregivers of people over 60, which is specifically what the grant is for. It's not much, but I think that we can do a lot getting into the areas that are underserved right now. And Morton has transportation. Just to let you know, we have 14 buses, and people who come to our programs, etc., are Morton people. And they can actually utilize our transportation to come and go from the support groups.
Any questions for Grace? I'll get to start then. First of all, how do you evaluate if you're doing a good job or a poor job? What does the grant have? Like, you have to hit so many people, or how does that work?
Actually, there are 120 required activities a year. So that's 12 a month, big ones, little ones, and touching people. So to reach as many people as we can with the money that we have. That's correct. And to try to diversify so that we're providing all kinds of services, not just one kind, not just one place, not to just one kind of person, but to really diversify as much as we can into workplaces. If we can have some support groups and workplaces so that people don't have to leave work for that support, then they're still at work and they're not losing money and they're not asking for time off. If we can get into churches where people already are, then they're getting support in an environment that they already understand and know and are comfortable with.
I'm just curious, but I've noticed growing around our metropolitan area, we have a lot of cancer centers, your chemo centers where you go for radiation and chemo. And as you see people going in and out of their spouses and others, I don't know if they realize they're caretakers or not, but are those places, is there information there? Because they may, like you said, if 40-some%, I think Margaret or someone said, don't recognize themselves as caregivers, but they are. And if you watch them over weeks and months, they begin to look as bad as the person they're caring for in some cases. And you can tell they're at their, I can't imagine you having time to write a book. I mean,
It would be really fun to write a book.
But I'm just wondering, have other states, because we copy a lot of things here, have other places done a better job at doing this? As we have an aging population in Oklahoma, so we're going to have more caretakers and more people who are going to need services but take care of themselves last. Who does it best?
Well, it's interesting because when Representative Goodwin asked me to come, the first thing I did was look up, how do other states do this? Let's see what their models are. And they have resource centers and things like that, but it's really hard to tell exactly where they go, who they serve, how they go beyond the resource center, which I think is what we need to do. Resource centers are awesome, but you can't always expect everybody to come to you. You have to bring it to the people. So interesting that you mentioned cancer treatment centers, because we have a meeting at cancer treatment centers, I think this week, to talk to them about whether we can help within their environment. I went across the country opening Alzheimer's centers and things. It's my passion, Alzheimer's and dementia, but that's where a lot of the passion is with this kind of support, and we need to break out of that being the only kind of support. So our goal really is to look at heart disease, look at cancer, look at diabetes management. Caregivers are expected to keep people with diabetes healthy without knowing anything about the disease and what they can do as a caregiver. So I really want to make sure that not only do we reach people in different places, in different ways, that we reach people that have specific chronic conditions and be very specific about what kind of support we provide to them.
Just as a follow-up, I know we have grief therapy when we lose a loved one. But do we have therapy for caregivers or classes? Ms. Love mentioned, how do you teach caregivers if they know who they are? Some of us know, some don't. But I've never read a book, to be honest with you, gone to the library to pull out a book. I recognize I'm a caregiver. But do you, and I know at OSU Medical Center for a while, we actually had a gerontology unit. But as funds were cut to that center, that was cut because we stopped the recurring people through the emergency rooms through, just the wrong medicine, the IAs because of, and dementia, early onset of dementia because their IAs were out of control and stuff. So I just wondered if that, you see that becoming a niche
in
therapy for caregivers.
Yes. And there are some resources in Tulsa, and they're the ones that I'm more familiar with. I worked at Life Senior Services as well. I ran the adult day centers there to provide services, and we deal. When you admit an older individual, you enroll their caregiver, and you provide just as much support to that caregiver. So I think that there should be a niche. There should be concentrated services for seniors and their caregivers, and you have to do a caregiver assessment. You have to know what the burden is for that caregiver for that whole thing to work, so that person doesn't become less healthy quicker, and then the individual ends up having to go to a residential, which there's a place for everything. The continuum of care is really, really important, but the reality is that people want to stay home as long as possible.
Representative Goodwin, you're recognized to ask a question.
Thank you, Representative McDaniel. I wanted to ask I know money is important and vital. And so what happens for the folks that have the vouchers now, the quarterly vouchers for respite care, et cetera? Mm-hmm. Can you go into that a little bit, and how much is, and how do we expand that, or how do we get folks to know that that's even available? I literally talked to somebody yesterday taking care of their loved one, and they just said to me, I'm on lockdown. I can't go anywhere. I can't do anything. And they weren't saying it begrudgingly. They're like, because I was like, are you going to go to such and such? It's like, oh, no, I'm on lockdown. To use the term lockdown. I was
well,
like,
that's
wow.
very prison-oriented, isn't it? And caregivers like that, how do you survive in lockdown forever? You're not going to. I had a family member who was just so bitter about the service she was providing. And again, we need family members to feel not guilty about taking a break for themselves. And the state has a lot of resources. We have respite vouchers. I think it's $400 or $450 every quarter that people can use. They can use it for adult day and home care. We have the Advantage program that also provides respite for caregivers. So there are resources out there. People don't know about them, or they don't know they're for them. or they don't know how to get them. And so it's really, really important for us to provide these services and education so that people know what's out there. I was speaking to somebody from INCOG the other day. We had somebody who was going to need a little more than $400. She's like, you have them call me and I will grandfather them and they can have a little more than $400. So there are ways to get around even the cap because there's money. Once they run out of the money that quarter, there's no way to get it. But there seems to be money right now, and they want people to access the vouchers or the money goes away. And we don't want that to happen either. There are also homemaking services through the INCOG Area Agency on Area Agency on Aging, and but that is at a premium. There's never enough for that. That's one of the things people ask for first. I know my mom would love to crawl on her knees and clean her kitchen floor. Not me. But she would love to still be able to do that. Obviously can't get up. So she doesn't do that anymore. So that's one of the very first things people ask for because it is so hard to actually keep your home clean. Anyway, but that's what we need all of this for. We need people to know what the resources are, and they're there, but they're not accessing them.
Yes, you're recognized.
Just one last, I know we need to wrap it up. I am concerned about the folks that go to work every day, and they also have to take care of a loved one or a friend, etc. Any ideas on the horizon in terms of what our employers can do to assist with their employees when their employee says they get the call and someone needs help right now and you literally have to leave without, the repercussions of, well, if you're not going to be on the job, we'll have to find somebody to replace you.
People leave work every day. I leave work when I have to. When my mom calls, if I'm in a meeting, if my mom calls me right now, I'm answering the phone because you have to. And you do leave work. And hopefully you work for a place that really understands that. If they don't, you're not going to work there long. You're just not. You're going to find a place where they do understand it. But what can work do? Work has daycare. I mean, work could actually, Lance put up the whole list of maybe tax credits, maybe this, maybe that, maybe some kind of relief so families can afford something that they can't afford right now. Adult day centers are a perfect resource for families. Nobody knows about them. Nobody in Oklahoma, best kept secret in town in Oklahoma because it's just not a resource that most of our families access.
Thank you very much, Grace, for making the trip over. And I wish there were a way that we knew that the AAA wasn't AAA. And but that's an education, advertising, marketing challenge
funny.
way beyond my pay scale. But you're right. Letting people know what we already have in place would help too. So thank you for making it. Good luck. Do you want to wrap this up?
Yes,
Representative Goodwin?
I just want to say thank you all for the work that you do every day, day in and day out. There has to be a particular kind of passion and love to be involved in what you do because folks need help and you guys are there. So thank you for that. Thank you for sharing with us where we are currently and hopefully how we move the needle and become even better than the sources, resources that we're providing and the care. So thank you. Thank you, Representative McDaniel.
Meeting is adjourned.